Hello, everyone. Welcome to this week's Health for the World Grand Rounds. Thank you for joining. We are so happy to have you here. Please feel free to introduce yourself in the chat box and tell us where you're logging in from. We will have a Q&A session after the lecture, so please add any questions you may have in the Q&A box. It's my pleasure to introduce our guest speaker for this week, Dr. Bhishak Kamat. We are honored to have him today, and he will be giving a talk on the Radiology Report. Dr. Kamat is an associate professor of radiology at Temple University. Dr. Kamat completed the clinical radiology residency at Cooper Hospital University Medical Center, his abdominal radiology fellowship at Thomas Jefferson University Hospital, and his nuclear medicine fellowship at Hospital of the University of Pennsylvania. Dr. Kamat's research interests includes both clinical radiology and nuclear medicine. His work has been published in several peer-reviewed journals and has been presented nationally. Hi, Dr. Kamat. We are so honored to have you here. Thank you so much for joining. Please start whenever you're ready.
Well, thank you very much, Dr. Mustafi and the crew for the Health for World. It is really a pleasure for me to provide this lecture. I love this topic, as I'm sure many of you do too. And I'm sure there'll be anticipatory questions at the end. I'm happy to entertain. I've got my timer set here. I should be stopping around 15 minutes left, so there should be plenty of time for questions. This is my first international opportunity to talk to an international audience, and I'm really excited about that. So thanks for that privilege and opportunity. With that said, let me get started. I think people can see my slides. People can hear me okay. All right. So
yes.
Advance. So before we go into my lecture, I would like to break the ice with this pyramid. There are various kinds of learning pyramids, as you know, philosophically, but one of the ways people have learned to learn is that this pyramid here is that our retention rate, and that's those percentages on this pyramid, is the least, believe it or not, by these lectures, unless they're somewhat interactive. And so obviously this is going to be hard to make this interactive, but that's the point of Q&A. So I encourage you to think through this lecture of questions and things and take the opportunity to ask, because I can certainly shed some insight from what I know on the topic. So in general, the participatory teaching methods, group discussions, practice by doing and teaching others, is the best way that we tend to retain information. I wanted to, I think it jumped a little bit. Whoops. Okay, sorry. I want to start with this article that's come from How to Create a Great Radiology Report in Radiographics, which I think highlights some of the important points. The most important point is on the right side here, and that is that, moving this out of the way, and you can see my laser pointer, 86% of residents in the United States have 1 hour of didactic instruction annually on reporting. And that is not good, because reporting is an element that we need to emphasize, because that is the most important product. And I want to emphasize these points from this article supporting that. It is the most important product that radiologists generate to help direct patient care. Radiologists usually receive little or no formal reporting education during training. Instead, it is learned in the so-called piecemeal and indirect fashion through occasional correction and imitating the reports of other radiologists. And some tenets of what a report should be, which I will continue to reiterate, but I think it's well listed here, and I will reiterate these points. Findings section should emphasize short, informative, factual observations while avoiding inappropriate interpretation, excessive use of perception, and redundancy. And the impression is a thoughtful synthesis of meaning of the findings leading to a diagnosis, a differential diagnosis, and management recommendations. The impression should use language that is understandable, memorable, and actionable. Reporting skills, therefore, require an ongoing attention and must adapt to the evolving practice patterns. So my outline for my lecture includes the elements of a report, which will be emphasized in multiple times. There'll be a lot of repetition. I'll provide some examples. And then I want to kind of have a little time philosophically to talk about certain tidbits that I think come into workflow dynamics and how we look at things that is not necessarily report, but it's how we engage and interact with reports. And I sort of coined some of these terms, or I've read some of these terms coined, and you can see those listed. So why am I giving this lecture? Why is reporting important? Well, number one, is it's an underemphasized topic, fact, yet very important in the medical legal realm, fact, right? So we need to pay attention to our reports, and reports, more importantly, I always remind people, reports are a representation of us, not only in the medical legal realm, but also in rapport building with your referring physicians. And I do have a pledge here that we are not, there are many ways to do this, right? I'm just saying reporting is important, but there are many ways to do that. And so we don't want to create a sense of division between our systems, that my report is better than somebody else. That's not the point. The point is to incorporate tenets from this lecture and modify it to your own needs and to your own system, because there are going to be certainly local stylistic and necessary things based on what you locally do. So that's the pledge, that we are going to work together and not be divisive. That's important. So the purpose of a report is two most important reasons, right? Top two reasons for malpractice is a failure to diagnose and a failure to communicate. And both of those elements can be controlled via reporting, right? So the interpretation guides management. And one of the ways I think I encourage residents and trainees to do this is to attend tumor boards, or so-called multidisciplinary conference. I'm sure you have that. And I think as you figure out your reporting style, I think one of the ways you're going to learn that is by knowing what the management of these cases are going to be, right? If you can better understand that, then you can tailor your report to that. So I think attending some of these will be important. So it also, the report covers you legally and ethically, and there's a certain level of responsibility attached to it. It is the medical legal document expected of a radiologist. What you say, what you thought, what you read doesn't have equal weight, right? So what I'm saying to that is I've seen plenty of really intelligent radiologists, right, that don't have that conveyed in the report, right? Or vice versa. Somebody who's kind of an average radiologist but has put in the time on the report that makes them look like they know what they're talking about, because at the end of the day, it's the report that carries more weight than what is in your mind, what you meant to say. Those things don't have the same weight as what is said. So that's why reporting is important. So now that I've set the tone for the reporting being important, I think we need to understand this communication concept. So number one, you need to tailor reports, in my opinion, to various entities, right? A report going out to a general practitioner, mine, is not the same as I report out to an OB-GYN doc, or to a urology doc, or to a hemonc doc. And considering I'm dual certified in nuke med body, you can imagine I have a lot of referral bases, right? So that's important. So tailoring to referring physicians. Number two, be clear and be concise in your reports, right? Brevity is the soul of wit, in my opinion, on reports, because the more you say, the more noise to signal rather than signal to noise, the more confusion, the more typographical errors, the more you are prone for medical legal ramifications or errors, right? So clarity and conciseness is important. Number three, participate and engage with the clinicians, whether it's the phone calls. We have now Radiant, which is a form of Epic. Epic is universal, I think. And so you have the Radiant, which creates an automatic bridge now. As soon as we open up the patient case, it connects right to Epic, which I think is very great to kind of dig into the history. A lot of specificity of how you want to say something comes from knowing the clinical context, right? We do not read in vacuums. So this is a supporting document from that article that supports my thought that there is a report audience, the reporting radiologist, right? And the needs from the report is to be technical, organize your thoughts, provide complete evaluation. But you have other radiologists, they need to follow up on your reports. So if you have, I'm sure you've seen, you read a prior report and it's prosic and it's got a lot of stuff in it and you can't find things, you get frustrated. So then you have to think about that when you generate a report for the next person. So it's a team game, right? Then we're talking about these other audiences, primary care providers, who need these things, specific recommendations for treatment, etc. Subspecialist physicians, will need specific recommendations for specific subspecialty entities. Patients, you have to be careful now what you say in your reports, because the patients can access the report. So if you said something that's not, going to sit well with the patient reading the report, you got to be careful about that. Billing needs certain elements in the report, right? Researchers need certain elements in the report. And lawyers want to see these reports. So this is tough. It's just like giving lectures sometimes. You have 8 different audiences to think about, right, when you give a report. So that's important. All right, now let's get into the nitty-gritty of the report. So I've termed this thing, and a lot of people love it in my institution, it's called upstairs and downstairs. Now, the first time I said that to a resident, they started looking upstairs. I said, no. This is something I just coined for the report. Upstairs and downstairs. So upstairs are the findings. So I would like to emphasize a certain point. Number one, when you have a lesion or a mass, I think certain elements have to come with it. Point one. Point two is I emphasize positive findings in my report. One of the ways I concise my reports is I emphasize positive stuff. I don't waste a lot of time in talking about negative stuff unless it's really, really pertinent. Okay, and we could talk about certain examples. But for the most part, I am one of those people that mention when I need to mention. And that's important to keep things concise, in my opinion. Now, let's talk about mass. So with a mass lesion, I think certain things automatically should walk through your mind. You should do it in an organized fashion. The size of the mass or lesion, the mass effect on the vessels and nodes. And then here's a fumbling thing that I see all the time. The proper terminology for the proper modality. Remember, we're the radiologists, and you have a responsibility to share your technique of what you do accurately. And what I mean by that is this. When you're talking about X-rays, right, you're talking about densities, or CT, you're talking about densities, right? When you talk about ultrasound, it's echogenicity. And when you talk about MR, it's signal intensity. So I've seen many reports in which we fumble, density, and we're talking about MR, right? And it just doesn't work like that. So you have to be cognizant of that. I do think we have a responsibility to be careful to that level of detail, okay? Even in a busy practice. Positive findings, I talked about. So here's an example of what I do with what I call lists of lesions, right? So I'll say few fibroids, and there's a concrete example I'm giving you. Represented as follows: F1, XYZ centimeters, semicolon, where it is on the x-axis, where is it on the y-axis, mid body, such and such, and the enhancement pattern. I keep it the same way for F2. Now listen, it's a simple concept. This is a very simple concept. I've seen people mingle this. So they'll take, first of all, they won't organize a list. That's a problem. Problem number two, they'll take this and they'll put this intramural ahead of this. That's not good, right? You have to try to keep it in a columnic fashion. A, organization, and B, presentation, right? Optics do matter here, all right? So yes, even though some people say, that's kind of picky, I put mid body here, I put fundal over here, and then I put the part. What's the big deal? It is a big deal, because you have to think about, you're not thinking about your audience when you do that, right? It is a big deal. Downstairs is the impression. It's the Picasso. It's what you think is going on. You get paid as a radiologist to tell what you're thinking. It's not a rehash of the descriptions. Isn't. It just isn't. So as an example, when you talk about chest X-ray, you talk about, I see, interstitial, intralamellar septal thickening, and I see infusions, and I see, big heart. findings compatible with CHF, right? So you have got to synthesize. That is important. And I would say the other point about downstairs, the impression is to stick to 3 points. 95%, I read some complex cases, 95% of my cases, especially if they're outpatient or EDs, have 3 points. I can tell you right now, 3 points in the impression. 3 is a good number to keep in mind. People can, people like the 3, right? So I like to put 3 points only. So number one, so what will go in that then? You're being so meticulous in what you put. So what are you going to put in these 3 bins? Number one, answer the question. Very important. You don't have to answer it accurately or finish it. You do need to attempt to answer it. What I mean by that, not accurately is not the right word. What I'm saying is you do need to answer the question. For example, they're asking you, are there gallstones pre-bariatric surgery? You have to say they're gallstones or not, but there might be limitations that tell you I cannot tell it on this modality because of motion. That's fine. That's allowed, of course. But you do have to attempt to answer the question. You cannot evade the question. That's an important point. Number 2, life-threatening stuff. I think we're good with that. We tend to put the life-threatening stuff pretty well. And things that change management follow. So many times now, we have many things, as you do too probably, that have unexpected findings or other sections, right, in the impression that are separate, which allows me to have an extra bin here now, because usually these are my top 2, let's say, and now I can fill in something else because unexpected finding goes even at the bottom. So I get another free slot. Great, so and many places now have these things for the change in management. So let me now go back into particular sections and elaborate. So number 1, history. Look at EPIC. EPIC's or electronic medical record, by the way. Look at it. It is your responsibility to find and report some history, right? So look into EPIC to add some history. And trauma patients, where does it hurt? Like where are some external signs of injury in the belly? That's important history. I tell the residents, put that in. Put pertinent points only, because remember, the conclusion is to kind of answer the question. So sometimes we get a code 5, 6, 8, 9. I don't know what that means. So then you have the opportunity to dig in and create a question that you're going to answer. You can do that. There's nothing wrong. But then, you have to figure out the question. The most important thing in radiology, my opinion, if you're going to have a good report, is you got to know the specific clinical question. That is how you become a good radiologist in answering questions. Because to answer, you have to know the question. And then you should add pertinent treatment things of radiation and chemotherapy and immunotherapy, and put the dates, right? Put the dates. Is it in between from the prior study, right? When was the surgery? These are important things. And especially as trainees, you really should be putting a lot of this information in. Right? That's how you learn, right? It's really important. Technique section, comment on the protocol. Ultrasound, have a grayscale, color, spectral Doppler is used. That has to be commented on. IV contrast, was enteric contrast given? Was IV contrast given? Yes or no? The dose in nuclear medicine, the dose of contrast also, right? Artifact and limitations. I see, remember, as an example, the orthopedic doc knows to read the fracture. Right? They may not necessarily know the limitations of an artifact that affect that interpretation. Right? So artifact and limitations, what you don't see, what is excluded, is equally important in a report to mention, not only from a medical legal round, just from a completeness of a report. And then patient-related issues. Now, the one thing I will comment here is I'm hesitant to say things like, patient was fighting in the scanner, or patient was too big or something. You got to be careful with judgmental terms. I'll say, due to patient conditioning, patient declined this imaging. So I do have some art in my report, because I'm always thinking, who's going to be reading? Back to that other chart, right? Who's reading this report? Finding section. Positive things should be described in detail with goal of summarizing impressions. So the way I increase my signal is I focus on positive things. If I find a mass lesion, I will make it a point to mention the size, the mass effect of this. I'll elaborate there, and I'll poo-poo things like, atelectasis, right? So remember, the way I look at it is, So one good way to look at it is you have a finite number of characters. I wish reports had like that. 10 characters and you stop, right? If we had that, then you would have to forcefully figure out what is going to be important and what is not going to be important to mention, right? As I said, downplay the other lectures is be organized and prioritize the finding. I've come up with a new term actually this year. I've come up with this. I call it mingling, right? So what many trainees do is they will mingle. They'll say cholelithiasis without biliary ductal dilation, right? Cholelithiasis. So remember the gallstones often have to do with the gallbladder. Yes, hepatobiliary system is a system, but unless you have a stone in the common bile duct, the gallbladder dilation shouldn't affect the biliary ductal system, right? So you don't just mingle everything into one, right? So again, it sometimes takes a little bit of just a second of thought. So one of the things I say is one of the ways you know a good report or not is you close your eyes, because often we know what we want to say, but we often don't say what we want to say. That's an important point. So closing your eyes and thinking about what you just said, is that what I'm really saying, is important. You often, trust me, if you have not done this, at the initial stages, you will catch yourself correcting a lot. And that's a good thing, right? Template versus no template. Well, that is debatable, but obviously the majority of the people in the United States are using template reports because of a variety of reasons. The one advantage or a real concern about the audience that likes the no template is the fact that they say, well, if some pathology, this is well written, occurs across multiple sections, it's difficult to template. I feel forced, right? That's the no template group. I feel forced. Well, there's a way to handle that though, right? In the template report, because you can say, you can make multiple sections, retroperitoneum, peritoneum, extraperitoneum, and then mention the whole thing. And then you can say in the nodal section that, hey, as above, mentioned in this section. So there are ways to handle that. I think there is enough room in the template report that you can account for that. But templates definitely help in many other ways, which we may talk about, for reporting. So I am favoring templates. Comparison date, image, number, and series. Okay, now this is another area that I see fumbled. So number one, I do not encourage saying multiple, and I see this all the time, multiple studies dating back to. I don't like that. A variety of reasons. Let me start with the most important one, is a medical legal reason, right? When you say multiple studies dating back to X, you are relatively responsible that you checked all those prior studies, at least for the finding that you're talking about, right? And remember, things can change up and down through all those studies. So yes, if you did A and then went to PET and then you came back, fine. Those pertinent ones that you checked to put in, of course, and then you should put those dates in. I usually call comparison for things that are like-minded, like CT to CT, and correlation to things that are semi-like-minded, like you go from CT to PET CT, right, or MR. So, but it's important to only put the comparisons that you're talking about. That I do think is important. Number two, I see this all the time. The resident will find something very small on some series, right? A nodule or something here, there. And now we can put arrows, but sometimes they don't do that. But I would say put arrows, mention the series and image number, right? You have to understand, if it took you 15 minutes and that was your case, it's going to take the attending a few minutes to find what you're talking about too, if it's very small, right? Or the next reader for the follow-up. So you have to mention series and image numbers when you're dialed in to a particular small, finding. Pertinence is the description in a report appropriate to the clinical scenario. So if it's a trauma case, I don't just say mediastinum is unremarkable, no mediastinal hematoma, right? Or pneumothorax or pulmonary contusion. So that group of finding pertinent negatives. So this is what I talk about, some pertinent negatives. This is the kind of stuff I'm talking about, but it's really important to the context at hand, right? And important things like no mediastinal hematoma, okay? And lexicon, for a lot of lexicons, you have those things listed, and avoid judgmental words like these: satisfactory position, poor inspiratory effort, patient became non-cooperative, etc. A lot of my lecture points came from Dr. Kovacs, my trainer at Cooper Hospital. He made some of these great points. So positive findings, description of unexpected findings, all these things come listed as part of that. Impression, conclusion is not a rehash of the findings. You have to rank them to some degree, which I alluded to, answer the clinical question, life-threatening acute findings, major findings, unexpected findings. Again, this is where I disagree a little bit. People say, don't say see above. I do, CYA a little bit. Not sentences, paraphrase, be succinct, yeah. Know the reader. We talked about these things. So this is rehashing some points. So corrected report. If the final, this is important. If the final report, I'm talking about attendings and people who are signing training reports. So if the final reports varies from a prelim, right, you need to remark that and what the change was. You can't just change the prelim thing and just put your thing, you have to talk about what you changed, right? Or at the least, you should have a prelim X time, final report conveyed, whatever, at B time. So it should be clear, because they can always audit trail what the prior report said. That's not a problem. But then you need to tell what, you need to make it clear that there was a second report rendered on that. That's not medical legal realm. Document to whom the corrected report was called and when. If new information was received, then you should put that in, obviously, because that changed your version, right? Now let me digress for a little bit into, let me see where I am in my slide stuff. Okay, so ownership, conveyor belt theory, and satisfaction of search. So ownership is a really important point in radiology, okay? One thing I'm very proud of, when I started my first year residency in radiology, is that I owned my reports. What do you exactly mean? Can you elaborate? Yeah. So when I sent my first report as a radiology resident, first report, okay, I made sure the things in my control I own. In other words, I first got in my mindset that if I'm sending this to my attending, it is my report. Even though medical legally they're responsible, I get it. But at the end of the day, my report that I send to my attending at whatever level I am is my report. And so I have to take that ownership, right? And what that means is the things I can control on it, I should have good control on it. What I mean by that is on that first year resident, right? If I have I can proofread it. That's something in my control, I think, right? Knowing that the comparison dates are proper, right? That's in my control. I might not have all these modalities, but if the CT says it's from December 2022, I shouldn't be saying it's from December 2021. That's in my control, right? Knowing that the sections of the report are there is in my control. So you see, the point I'm trying to make is that every stage in your training, there's a lot of control of what you do know, even though you don't know some other things, you have more control on it, right? Because you also got to understand when you start, right, you might read, just making up the numbers don't matter here. No, let's say you read 4 studies, right? Well, you can control a lot in that 4, can't you? When you read 15 studies, it can be hard to control those 4 factors, right? So that's ownership. Very important concept. Number 2, the conveyor belt theory. The patient, when they enter the hospital system or the ER or outpatient imaging situation, are part of a long journey. And especially in the hospital setting, they're in a part of a short journey or a journey at that moment with their acute / unchronic finding, right? So if you remember that, and you remember that they're coming in, how are they coming in? Through an ER, to an outpatient situation, or the inpatient in the SICU, right? So like knowing where they are on this circle, knowing what the management of what you're finding is the idea of a conveyor belt theory. Right? The more you can figure out, which is why I think some of the advantageous trainees are the ones that have surgical backgrounds and things, because they know the management. And when you know the management, you can then tailor that report towards that. So that's the conveyor belt. And the third is satisfaction of search. I love basketball, so I'm going to give that basketball analogy. It's like the free throws. right? It doesn't matter. Some people shoot free throws underhanded. Some people shoot free throws like this. Some people shoot the free throws like this. That's my visual for the lecture here. But technique of how each one does is important. And the great shooters, right? If you look at some of the top shooters in the NBA, Ray Allen, Steph Curry, right? If you ask them, they shoot like 1,000 shots, I think, in practice, and they get the muscle memory from it, right? They shoot it the same way. And that's how I liken to radiology. The name of the game in radiology is search pattern. I mean, is pattern recognition. So it's a very simple concept. If you create a muscle memory, one person might have an A sequence, one person might have a B sequence, somebody might have a Z sequence. That is not relevant. What's relevant is you have your own sequence that you do not deviate from. That is important. Because one of the ways you make the majority of findings is by being extremely, if I may argue, disciplined in your search pattern, right? And I will also go on to say that the best radiologists are the ones that can make the finding, because you could have all the differentials in your mind, but if you don't make the finding, the differential doesn't even come into play, right? That's important. Satisfaction. So these are nice 3 tidbits that I want to share that are related and important in radiology life. Now, examples. Linear areas of increased density. Sample report, random sample report. I'm not interested who it is from, but I'm just giving a sample report that is reality report. Linear increased density, left lower lobe, reaching pool surface, upward shift, this. Now, this is good for your learning, right? That's a lot for the clinician to digest in this, and will ask you a million questions on some of this stuff, right? What are we getting at? That's it. Or I would even say subsegmental atelectasis at this point in my career. You made that judgment. You can talk it through now. The first you're doing that you want to go through, that's fine. But then I would argue we can talk about these things. Ultimately, the attending is going to have to put a report, and I would say the report should be something like that. Example number 2. Conclusion. Like this is definitely no story. Conclusion, right? Now here's the problem. Number 1, this is not a prioritized list, right? Clearly, why would you tell them the first thing in your mind about atelectasis, right? You want to prioritize, you want to keep the lefts from the right. So here's an example. Same thing, signal to noise. Look at this, right? It really highlights the most important thing, the next most important thing, and the next most important thing. So that brings me to this concept of signal to noise. Signal to noise, we study a lot in physics, and we all understand, oh my God, that is so noisy, I cannot get, but do you know signal to noise in 2 points? Number 1, you looking for information in people's epic records, signal to noise, and you on your own report, signal to noise. I don't think we talk about that, do we? So when looking at epic, so one of the things I do, I'm the clerkship director for medical students. And I'll tell you, first thing I do when they're working with me is I let them look up epic information. And I'll tell you, after doing that about like half a day with me, they're frustrated because they cannot find these informations in the records, right? And I said, that's great. Because remember, majority of them are not going into radiology. They're going into other fields. I said, this is good. This is good. You're frustrated because this is a great opportunity for you to realize how then you need to present that information. See, but the part where we need to get better is we need to learn how to communicate across areas, right? And so this is how we learn that stuff, is through the experience. And so, and then when looking at the images, search pattern, and when dictating, organizing, and presenting. So this is how you improve your signal to noise. The search pattern approach, right, gets you the efficiency, the dictating and organizing your thoughts and knowing about the readers, and then teaching medical students and the future comers of how to order and how to, right? You have a mentorship role there, right? You should take it. Here's an example, a simple example. You might say, oh, this doesn't look that bad. Well, I would encourage you to put something in between these things, because if these things kind of come closer, this becomes a 1.3 centimeter thing, right? So simple things like that, right, make a difference. Example number 4, left renal mass, right, left. So you kind of jumping between left and right, and then the impression says left. So I try to sometimes even highlight my lefts and rights, so that, because that's one of the commonest mistakes, especially when you switch between nuclear medicine and body, because sometimes the right left switches on those cases, right? So pay attention to those things. Okay. And this is an example where you're talking about, okay, so lytic lesion in the bone, let's go through that. So let's go through this point. So hypermetabolic indicates malignancy. So using particular terms with particular modalities we talked about. Now, see, here's the thing about lucency and lytic. See, I tend to use, this is important. I use lucency when I'm indicating benign and I'm not sure, right? Because words have connotations. We know the buzzwords. Once you say lytic, right, you're kind of implying that it is bad, right? So the reason I bring that up is because if you say lytic and then say this is likely benign, I think it creates total confusion for the reader. Total confusion. Because we are already primed up and ready, and when we hear lytic on the board exam, we're thinking it's bad, right? So those words have meanings, all right? Benign and malignant, good or bad? Is there a third choice? I mean, I see this too, like the people say benign or malignant radiology, good or bad. Is there any third choice there? And who cares about normal adrenals in the impression, right? That can be buried. I call them, buried means put it in the upstairs finding there. Structured reporting we talked about. These are some of the things about structured reporting. All right, so sections of a report for trauma, add where it hurts, check EPIC for what cancer, what therapy, LMP for pelvic ultrasounds. I'm rehashing certain points. Technique, IV contrast, MRCP, MRC, these are billing things. IV contrast, what kind, 15 cc's, doderam, MRCP, Doppler was used, artifacts, findings of upstairs, preferred template age, start with standard field templates. Remember, templates are just that. That's another problem I have, right? People say, oh, you want your templates, I want your template. I'm confused. It was not in the template, so I didn't fix it because the template said that. So you realize a template is a blueprint, right? Ownership is your report, right? So templates can be from anything, but then that particular report is going to have to be modified, including the templated parts, right? So I don't like to hear that when people just say, they use that as a crux that oh, that was just in the template. Well, any template, you have to modify it, right? It's on you. Conclusion, use bullets, and then recommendations, follow up, unexpected findings, results communicated with. So I want to talk about that shortly. Upstairs, downstairs, spell check, definitely compare revisions, right? This is what I encourage. We have these things that allows the trainees to compare to the final reports. I encourage them to do that every single year. And the ones that do that improve the reporting. I wish I could write a little research point on that, but that is the truth. 5 elements of a report: when, how, where, when, and what the report is. And then this is important. So medical legally, when you talk to somebody for a critical result, these are the elements that are important. How did you communicate? Telephone conversation, electronic message, what time, what date, their full name, their title, right? And with acknowledgement, you have to indicate that there was a closed loop conversation. That's legal. That's important because that can come and bite you. And I'll tell you right now, documentation is important. Even if it's minor stuff, whatever, we underestimate. Remember, one of the biggest reasons for badness in cases is because of there was no documentation in the report. Right? This is a medical legal thing, so you've got to document. Very important. So my 4 years of trainees, my thought is in the first year, you're kind of working on reporting and search pattern. Number 2, you're handling the cases to figure out what's normal to abnormal. And that's when you make the transition to a senior, when you're generating a good report. And by the 4th year, generally should be signing away most of those things. We're getting close to the end. Take a deep breath, right? As if you're talking to the referring doc and you have 1 minute or less to get the point across. and also in a ranking fashion. So I always say that take a deep breath is not facetious. That's really important. When you go from upstairs to downstairs, take a deep breath. Think what you want to say and then write. Don't just jump. Don't copy paste from the findings to impression. Bad idea. And the other thing is, as you become senior, I have an advice. This was great advice given to me. You put the impression first on the cases, right? Because that's how it happens. If you have a lot of cases, right, like PET CT, even complicated cases, you got to think, okay, let's say the clinician called me in 5 minutes. Many of you know what to say. I know you do. I have full faith in what you need to say. Say that in the impression, like to the points, and then go fill in the blanks. You'll see your reports will get better because you realize that, okay, the part of the problem is to kind of fit what you want to say to what you want to conclude, right? The way you do that is you make your conclusion clear, or you connect that, right? So it's always about like 1 + 1 = 2. What I often see is 1 + 3 + 5, and then we're trying to conclude to 2 as an analogy, or and so in other words, they're not matching. The findings are not well listed, and the impression is made correctly, or the impression is not made correctly and the findings are listed well, right? The latter problem can be trained pretty easily. The former problem is a bigger issue because you know what to conclude. You got that. And you said it well, in fact, succinctly. But your findings are all over the place that don't really come to that conclusion. That's a bigger issue to fix, right? Do not repeat the findings, only there if it impacts management. Make it clear, not a guess to what you're thinking, right? So this is where in the impression you should clarify why you're saying what you're saying, right? I would suggest not to say no further follow-up. I don't do that. Even though certain guidelines say that, I don't usually say no further follow-up, right, in my report. And then remember this pledge that a lot of this is my opinion. Ultimately, you are your own radiology report. That's my point. At the end of the day, you can listen to this, take your points, fabricate your own report. But you know, each one I understand has the stylistic components, but here's some of the blueprint that I think is helpful. So here's back to the point, deliver the goods. This is from the article, state it clearly, keep it relevant, think about the next step, and continue to grow. I have to tell you, as much as I'm giving this confidently right now, and I've been doing this for like, what, 10 years or something now, I continue to improve my reports. And I will also say, I learn from even trainees who give certain ways they say something. So one of the things I do, which I pride myself on, is people are shocked to hear this, and I'm surprised, is I read every single prior report that is pertinent. So let's say I'm reading a CT and a prior CT, I read the prior report. And when I say I read, I'm not just reading the impression, I read the full report. So that puts me at a distinct advantage. What do I mean by that? Number one, in my practice, I've seen everyone's reports 50 times. So I have pretty good idea how people report across the board in my sections. Right? I have the experience of knowing the blueprint, as you can see. And so then I take little tidbits from them to improve and layer up my report. Right? So it is absolutely a continuing to grow. And when I read this article, I also learned certain things. Right? So that's it. I finished even more advanced than my time. I said I was going to get to 15 minutes. So, okay, go ahead. I'll keep the clock running so that we kind of know where we are. Yeah, right about on time there. Okay, I will stop and I will open up to questions.
Thank you so much, Dr. Kamat. It was very comprehensive and helpful. I personally learned a lot. Thank you everyone for joining. If you have any questions, please feel free to post that in the QA box.
And I encourage, I want to say, look, I can't force you to ask a question, but you have a few minutes. I would encourage you to think of questions. In your practice, attendees might have questions, right? I encourage you to ask, because one of the reasons I'm doing this, obviously, I don't have to. One of the reasons I'm doing this is because I'm trying to build an understanding of a topic that I think is of interest. And I think we can all kind of learn from each other on it. And I think we can build on it, right? And I think it's a necessity that we talk about. 1 hour is not enough. right? So we need to kind of have, thoughts on it together. So I encourage you to ask the questions. I really do.
So our first question is from Dr. Minero. Thank you for joining, Dr. Minero. So his question is, what is the importance of diagnostic conclusion in the report?
What is the, I want to repeat it. So what is the importance of like the impression?
Yeah, the conclusion impression.
What is the importance? Well, I think that's, first of all, number one fact, I hope I understood the question correctly there. And if I didn't, please, re-emphasize the important point of it. But number one, the conclusion of a report fact is what majority of the clinicians read. Now I gotta tell you, philosophically, I don't like to hear that either. Okay. Medical legally, the clinician, at least in the United States, is responsible to read the entire report, period. It's not debatable. Okay. Because of their speed or whatever the situation that they're reading, the conclusion is on them, number one. The flip side on that, though, is since the start of the report to the finish, including, I'll answer the question in a second. I want to make an important point here. The start to the finish of the report is legally there. And so typographical errors, any other crazy things that you do upstairs, so-called upstairs, are also going to come and bite you. So the point I'm making is proofreading is important. And even though I'm going to emphasize the conclusion for the reasons we just discussed, all of your report is important, in my opinion. Number one. Okay, so the conclusion wise is important. Number one, anecdotally, clinicians tend to read that. So that becomes an important point. So with that said, then, I'm digressing slightly here. With that said, some of the people say that's one of the reasons I like start listing like 4 or 5 impression points, because I'm afraid they're going to miss something. Well, I am not for that, because I think if your impression then ultimately looks, even if it's not in long sentences, like 1/3 of your whole report, you are losing signal to noise on your report. I mean, if I had color coding, you would see that very clearly right away. You would see that. So I do think it's still important to kind of finite your points and to mention the most important points. And I think those are the ones that are going to be read more likely, and therefore will translate to communication. At the end of the day, we're trying to communicate. So I think having a really good impression of your impression and your thoughts, which is what you get paid for, is important. Pointing out a few points is important for signal to noise, because I think those heighten the chance of good communication and not get lost into the finite things. I think one compromise thing we see, Dr. Mustafi, is this. Now we have section, as I just said, many of us do, I believe, for unexpected findings and lung nodules that get follow-up embedded now into our impressions. So there's been a healthy compromise for some of those semi-important things that are already now have a place in the impression. So now we have even less of an excuse, in my opinion, to have more than 3 points. The times, if I may just elaborate, the times where I have more than 3 points in my impression are as follows. And that's what I said, like 5% of the time on my report. So 5 out of 100 reports, to keep it generic, are really complicated inpatients. I'm talking about body and news. Okay, those are the sections I'm reading on chest, body, chest, news. Really complicated inpatients, right? They have a lot going on, a lot of findings. Those are what, like 1 out of 25 cases on a day you read can have that. I understand that. Okay, so fine. So those are the few cases here and there. But on a global level, on 25 cases, if I'm 24 of mine have 3 points, the face of my report is always going to be when Bhishak puts something in the impression, I better chase it, right? So that's the other thing I want to just elaborate. I have an analogy, and when we had the oral boards, somebody mentioned this analogy. I don't know, don't laugh. This is my best analogy I can give you. I always think of myself as kind of like, an animal sitting on the side of the road, just watching the cars and things go by, right? Or like a police officer, sitting on the side of the road. If I see something crazy, I'll mention it and I'll jump on it and I'll elaborate it, right? But majority of the time, the traffic is going and it's fine, right? And I let it go. So it's like the opposite of the boy that cried wolf. When I speak, I want clinicians to jump to that, right? And when I'm not speaking, they know that it's nothing that important, right? And that inherently, I think, creates a level of respect for me and builds good rapport. And the other point I want to make on that, and I'm digressing to certain points here, but this is important, is I consider myself a young, budding radiologist, right, who is old school mentality in the sense that if I have any issues on my cases, right, I pick up the phone to talk to docs. We have so many means of doing that now. Tiger tags, this. If I'm burying myself and trying to figure out what the thing they're trying to ask, electronic medical record, if I'm trying to figure out is this abscess versus this, I'm trying to get some clinical context. Phone. That's the way you solve your problems. Is you pick up the phone. How often do we do that? Right? So the solution to some of this thing, if you get anxiety about is the clinician really going to know about that third finding, if you got a lot of anxiety on that, pick up the phone. It will alleviate a lot of your anxiety. I don't know if I answered that question. I know I answered a lot more on that question than somebody wanted, but that's how it goes.
Yes, thank you so much. And actually, we have received so many positive feedbacks. Dr. Minero says excellent lecture. Congratulations.
Oh, thank you.
So the next question, Dr. Shilwand has asked to please show references.
Please what? Share the references?
Yes.
Yeah, I can do that. I can email Abhinav because I think it's the article I want to send,
yes.
right? That radiology report article. But can I do that later in
yes.
an email to Abhinav?
Yes.
Okay.
Yes, sounds great. Thank you. And the third question, is it appropriate to use radiologic terms in describing pathologies?
Radiology, can you elaborate on that? I'm not sure I understand what you mean by that question.
Yeah, I'm not sure either. Is it appropriate to use radiologic terms in describing pathologies?
Does the person want to ask the question want to elaborate on that? Because to answer that question, I want to make sure I understand what we're asking.
Yeah,
here.
sure. It's posted anonymous. So...
Okay. All right. I'm not sure. I mean, let me put it this way. I'll take my own digression of the question, if I may, because there is an important point here. If this is probably not what the question is asking, but I think this is some other things that people are definitely thinking. These so-called eponyms and stuff. I know that's not probably what the question is asking, but I want to elaborate on the point. Is like eponyms, like in MSK and stuff, right? With the, what is it, Galeazzi? I don't do MSK right now. Galeazzi and Montagia, right? All those things. I would encourage people to describe things and then you can put in brackets. The other thing is, if you abbreviate things, like let's say peripheral zone for prostate, I usually say it once, put the abbreviation, and then you can use abbreviations. So one of the reasons I'm not just for throwing eponyms is because that's going to prompt phone calls, which brings me to the other point. Not proofreading reports, throwing in eponyms, throwing in things to sound great, right? A, you better be accurate on those eponyms, and B, the more flamboyant you become, if you will, in the reports, the more questions you're going to get. And so one of the more annoying things, at least for trainees I know, and for other attendings, is if you start getting continual questions on other people's reports, right, that becomes bothersome, right, for the workflow. So you do have to keep in mind, I'm not saying you shouldn't use eponyms. I'm saying you should try to describe things, especially since today in 2022, the patients are also reading the report. That's another reason I'll tell you that. Because, if you throw Galeazzi, they will not know. They will also ask the clinicians and the clinicians will ask you, right? So it'll be, and that's okay because some of that's education, but but I think you want to do that in every case you read, or you want to that's something for you to judge. But I tend to be descriptive. I don't have to worry about a lot of that because in body, I don't have I think MSK has like a lot of eponyms from my understanding. I don't have it that much in body, so I don't have to usually worry, but like hide scan, rim sign, I'll probably describe it and then put it in quotes and parentheses, that's a rim sign, right? Because the rim sign is also very classic, the clinicians are aware of, and it's a good teaching point, right? Those are buzzwords, so it's okay. But then I describe it, right, to make sure I'm very clear. And descriptions are well done. As I already said this, but I want to emphasize my litmus test, if that's a good word, litmus test for describing is like what one of my attendings told me as an analogy. If I am on, it's usually a beach or something like that, I'm relaxing and you're calling me in the middle of the night and you're describing the finding, I should be able to close my eyes and tell what you're describing. You haven't done that well, then you haven't described it well. I agree with that.
Thank you so much. The third question is from Dr. Manik Kawasakar. Whether template reports or normal report is preferred?
Oh, we're going back to this templated versus no templated? Templated.
Yes.
Templated by far. I'll tell you a few reasons why. Now let me elaborate on that. Number one, studies have shown that templated reports tend to move you through the cases faster, prone to less errors or perception errors. Remember, one of the commonest errors, right? They have errors of perception, right? And errors of interpretation, right? By far, we are in errors of perception. So how do you minimize errors of perception? Three things that I know of. Number one, focus. Right? I'm going to mention that first because I don't think people think about that. One of the things I do is I limit my distractions as much as possible when I read. I see like people hearing music and stuff like that reading. I could not do that. Number two, like somebody's calling me, get the thing down, I'm going to call you back. I do not get my eyes off my game. Okay. So that's point one. Maximize looking at images as opposed to the reports, and kind of, finish my report by looking at the images. So that's number one. And search pattern, right? Having a good search pattern, which we talked about, right? Errors of perception and good templates, right? In fact, now we have templates. Like I have templates. Don't laugh. This is important. Like I can. So what I do is I quickly look at my reports. I know all my normals. When I'm not in a normal, I say field. I don't know if your PowerScribe does this, but I say, I have it set up so I say field adrenals. Okay, and I'm looking at my image. I'm not even looking at my report. And I say field adrenals. That's the one finding I saw. And then I hit a ding. I'm in the field adrenals over there, and I put it in. And at the end, I just check my report. That's how I do my reports. So I already have everything normal. I'm looking and I'm continually, my eyes on images. I think that's how you minimize mistakes. And then having the templated reports quickly tells you the signal to noise, because the things that are normal in there that you didn't touch, you should have already known, proofread that's your template. So you obviously know that those are normal, right? That's how you also efficiently move through things. So efficiency improves, lack of errors. And then when you're also looking at prior reports, having templated reports make it very easy to find those sections. So those are all many advantages of a templated report. The only reason I brought up the no templated, I gave some respect to them for the genuine issue that they have about putting something, pigeonholing into a section. I think that's the only legit point of a no templated report. The non-templated report, otherwise, you've done this for some time and seen a lot of the non-templated reports. They tend to be all over the place, often because it's hard to kind of go through all that like that and then keep things in track, especially when you have multi-organizations like body, for example. I've seen some really experienced attendings who do it all the time like that. Still, there are sections sometimes missed or things missed, because those then have to be in muscle memory, right? So, and I understand it's an adjustment for people who have not done templated, right? Who I know are very fast with that. But what I will say is, number one, we all have to kind of move to a system, because then that allows for, research work and all those things and kind of standardization, right, within your divisions. You don't want to have template and non-template, which we do, which makes it really confusing, point one. So somebody has to adjust. And the second thing is, yeah, I find it hard also to find the stuff on the prior report. And what I would say, I'm sorry, the people that are going from non-template to template reports, because I want to respect them, because that's a big adjustment for them, I know. I would say it's like anything. The initial learning curve is really painful. Even for me, it was painful. And I was sort of bred in the time of the template reports, because I had to really look at my reports and make sure these sections and create these audio things where I say feel, liver, right, to make it even better. So even I had to make adjustments. So it was really painful in the beginning. What I would argue, it's like anything. The initial boulder is hard, right? But once you get into the rhythm, my reports take me very well. We have one person, I won't take name, is very efficient attending, who, and I'm not encouraging this, who, based on the efficiency of this kind of report, who taught me some of this stuff, right? He's like, 20 CTs in like half a day's work with the efficiency. So I'm not encouraging them, but I'm just telling you, but the systematic approach to these things help your efficiency also. It's back to that shooting the free throws thing again. And I think we have about 3 minutes, fair enough?
Thank you so much. Yes, we don't have any more questions. Thank you for the detailed answers and also excellent presentation. We are looking forward to having you again. Thank you for your contribution to Health for the World.
Absolutely. Oh, absolutely. And it was really my pleasure. And I hope if Health for World also kind of goes and gets even more broad, I'm happy to give it to other countries and things like that, because we are all one, and we need to kind of figure out how to communicate. And one of the responsibilities I have, and I'm sure many of the people involved here feel the same way, is I have to start thinking, look, I'm 10 years in, I'm already starting to think of my responsibility, not only to the audience internationally here, but also what I mean is the people coming after us, right? Is that we have to pass these things. Because at the end of the day, when I'm retiring, which is a long time from now, don't mistake me. I have to already start thinking, have I passed on the baton and my thoughts to the next generation of folks? I'm already thinking that already. So this is a wonderful opportunity for me to do that.
Exactly. That's so valuable. Thank you so much. And we have received this amazing positive response. Dr. Erwin says, awesome lecture. Thank you. So thank you so much. And thanks everyone for joining. Hope everyone has a great rest of the day. Thank you.
All right. Happy holidays to everybody.